So we could not get the custom live feed to work yet again. We had to just abort that lead, that custom live feed. So I'm going to go ahead and get started here under the, well, yeah, we're getting some people joining us. Great. If you could make a couple of comments, I would appreciate it. Thank you very much for your patience. I promise we're going to get this technology down sooner or later. We put several more man hours, about 4 more man hours of Clyde's time, Michelle's time, and about 3 more of my time today to try to get us up and rolling. Guess what? It didn't work. So I see Loretta Dillingham. Thank you for your patience, Loretta. Thanks for joining us. Trump Tribe 2020. I haven't seen you there before. Thank you for joining us. Thank you for your work. Loretta Dillingham, can see you and hear you. You're doing fine. Great. Thank you. David Ivers, good to see you again, checking in. Chalice of Immortality. What's the primary best way to prevent the chance of having a heart attack? Well, that's what all of this channel is about. I will say this, I mean, it's like many other things. It can get very, very complicated, but you can simplify it by saying, first, let's assess the situation. And that was one of the things we were going to talk about tonight. Here's what happens in the typical cardiovascular, quote, prevention world. Somebody has a positive calcium scan, or they have a family member die, and they think, you know what? I need to go get checked out. They go to the doc and say, why don't we do a stress test? And the doc says, that's a good idea. You do a stress test, and then it goes down a bad path, usually. There are better ways to go. And one of those ways has to do with first finding out, do you have inflammation? You're starting to hear about that more and more. Even the Time magazine had a cover article on inflammation about, over a year ago, 2 or 3 years ago. So it's even hitting the lay, non-professional, non-medical press, but it hasn't quite hit the medical community yet. It's clearly not the standards. I think it's going to take another 10 years or so before the standards catch up to the fact that cardiovascular inflammation is a major cause of immediate risk for heart attack and stroke. Now, those of us who are on the channel, those of us who've been watching the channel, know that we released a video a few weeks ago talking about how you can actually go to the lab these days and order, request and order your own cardiovascular inflammation panel. You have to do that sometimes because, again, your standard docs are not quite up to speed on that issue. So if they're not quite up to speed on it and they're supposed to be the professional, then quite often they criticize it and don't want to go there. Now, unfortunately, after releasing that video, it was an old video by John Lorscheider. It was accurate at the time, but since then, our major source for getting cardiovascular inflammation panel has closed their shop for patients to go direct. So, again, Bart, I keep using your name. Bart Robinson, by the way, says, good evening from sunny southern New Jersey. And again, correct me, Bart, if I'm wrong, but Bart and maybe some other folks have said, look, yeah, we'd love to do the inflammation testing. We know, for example, some folks have done it. I talked to, I think it was Nutrinuva this past week, who saw this on our channel and went to Quest and got the inflammation panel. And he's actually been following himself and his own condition for quite a few months on it. He acknowledged, he said, yeah, they shut it down. So here's one of our program points. I'm still able to get it. In fact, I did not know that that they had shut it down for patient direct requests. So that was one of the things that I wanted to talk about tonight. We're working out a way where we can make the inflammation panel available to folks through our contract with Quest Labs. Now, I had a full-blown slide deck which gave you details on it, both about cardiovascular inflammation and about how to get that through our contract. Unfortunately, that's what blew up. If you're going to show your screen and my face too, or even just your screen, you've got to go through a custom YouTube live, and we had both Clyde and Michelle. Couldn't get it done. But we do have our pilot available. Here's the thing. I'll give it to you verbally. If you would like to access the inflammation panel, pardon me, I'm going to go the old shaky paper, low-tech route again because the tech failed us, or we failed the tech. Michelle, I hope you're okay. Well, here we go. My health, and I don't have a black pen even. So here we go. PrevMedHeartRisk.com. Again, be patient with us. We're going to get the technology there soon. And Michelle, I'm going to give them your business number. If you'd like to order your inflammation panel, cardiovascular inflammation panel through us, another way to reach us, phone number wise, is, give me just a second. Okay, 615-538-8403. Now, somebody told me one time, quit apologizing for your technology. I'll quit apologizing for our technology when we get it right. Again, my apologies. But you can call Michelle at this number, 615-538-8403. And Michelle can help you get set up on ordering your inflammation channel. With that order, I forgot what price we're setting it up as. I think it was like, I don't know. I think it's like $250 total or $350 total. And what you get with that is the labs themselves plus 3 months access to the webinar program where we'll actually be talking about the results of the cardiovascular inflammation panel. So you'll get 3 months access to a weekly discussion and review of lab results and discussion about how to interpret them. And we'll be recording them, so you'll get that access to the recording for the 3 months as well. So I'll go back to a couple of questions. Jeff Earnshaw, what is the best way to test for cardiovascular inflammation? If you guys will bear with me, I'll go through some of this verbally. We use 4 tests. You could use other tests as well, but let me just go verbally through the process and then the 4 tests on the panel. You know, 147 degrees west, I see you're here. myhealth@prevmed.com, PrevMedHeartRisk.com, not PrevMed.com, PrevMedHeartRisk.com. Back to the point, 147 degrees west brought up the point a while back that we were not talking that much about the glycocalyx. The glycocalyx is a fuzzy lining of the arteries. what we are finding is, and the science is becoming very clear, we used to think, and most docs still look just at LDL. Well, here's the problem with looking at LDL. Half the people that have a heart attack have a normal LDL. So sooner or later, we're going to figure out that it's maybe not just LDL. And in fact, there's plenty of evidence, it's becoming clearer and clearer, that it's injury to the intima. And that intima is that fuzzy, has a glycocalyx, which is the fuzzy lining. Michelle, did I do the wrong number? I don't think so. So once you get the injury to that glycocalyx, then no matter what your LDL level is, the LDL can get through that glycocalyx. That's when the trouble starts. That's when you start developing plaque, because plaque is nothing but LDL that has become oxidized and lodged underneath that intima layer. So back to your question, Jeff Earnshaw, what's the best test? Again, we use a panel. It's a panel that was available direct to patients where you could order it yourself. Again, we found out the hard way a few weeks ago that it's not available direct to patients, so we're going to be making it direct through our contract with Quest and Cleveland Heart Labs. We look at myeloperoxidase, LPPLA2, HSCRP, and that's C-reactive protein. LPPLA2 is plaque 2. That's another term we use for it. MPL, hold on just a second. Pardon the tech issue, but we're getting them. Yes, Clyde.
Hey, Doc.
Yes.
You know what we keep on forgetting?
Yes.
Are you live now or no?
I'm live now.
You are now?
Yes.
Okay, yeah. I know what I did. I did something. Okay, I'll check it out. Okay, sorry.
Sorry. Okay. So again, plaque 2, MPO, HSCRP, and the most important one is actually a functional test to look at whether or not the intima layer is intact. That's called microalbumin creatinine ratio. And actually, that's a test that's done quite often by doctors in standard curative medicine. They look at a different cut point, and they're looking at a different thing. They're looking at the overall function of the kidney. The kidney is nothing but each kidney is 1 million filters, and each of those filters is called a glomerulus. You don't need to worry about what it's called. And a filter is nothing but a membrane supported by a structure. Here's why that's important. The membrane in the kidney filter is the intima. It is that lining of the artery wall. So if that intima is injured, it will let protein out through the urine. That protein is the most common protein in the blood, and that's called albumin. So if you have microalbumin spilling through the filter of your kidney, you're having microproteinuria, and that shows you've got damage to that intima. And guess what? That has been shown to microalbuminuria, or leaks of albumin through the kidney filter, has been shown to be a significant risk for heart attack and stroke. So those are the things that we use. Again, pardon the interruptions. Because of the interruptions, I'm just going to repeat them real quick. MPO, plaque 2, HSCRP, and microalbumin creatinine ratio. And those are the tests that we'll be making available through our contract with Quest. Again, I've talked to several viewers who are getting it on their own. And again, it got cut off, so we're going to make it available. We'll also make it available with access to webinars, which help us as a group, as a community, interpret these labs. So thanks for your patience on that explanation. I'm going to go back and go through some questions. Yep, it's working now. Slightly out of focus. I'll tell you what, slightly out of focus is one of the least of my our tech problems right now, but thank you for letting me know. The bit rate's slow. Here, let me go back and explain why. As you're seeing, I'm not in my usual $1 million LA studio. Yeah. As you know, I'm being sarcastic. I'm not in my usual studio. I stand up there. I'm actually in the, you can see, I'm in the offices here at K-Health. Some of you may remember it. I've done a couple of videos about K-Health. K-Health is, I drew an analogy between K-Health and medicine and Deep Blue and chess. You remember people say, people used to think that computer logic would never be able to beat a human in some deep relational type thinking like chess. Well, if you listen to Gary Kasparov, he's the guy that was the reigning champion that got beat by a computer. And he said, I beat it once, then I lost, and it will never go back. Computers are better now at chess than humans. We have never, until now, truly applied the power of computer logic to critical things like making a diagnosis. K-Health is doing that. And I'm a consultant to K-Health. I've been working with them for a few months. Actually, they just came out, I think. I haven't seen it. I heard about it. There was a Forbes magazine article recently about K-Health being one of the new startups in the health space to keep an eye on. Now, K-Health, the app itself, you can go to the app. If you have an iPhone or most of the other phones, go in, download K-Health, K like the letter K, and health. And then you can start asking it questions. You download your own demographics, you start asking it questions, and then it starts giving you some potential diagnostic situations. It'll go through the usual disclaimers. And here's the thing, K-Health has about 5 million doctor-patient interactions already programmed into it. So it's looking at experience, and there's no doc, even somebody as old as me, that has 5 million patient experiences to draw on. So you start getting some advantage there. Here's another advantage that the computer brings to the table, and that is, a doc has things like frustration with technology, people waiting to go out to dinner, your family problems, whatever. Computers don't have that problem. They think and go back through every one of the logic points when you bring that to the computer. Now, if you're thinking, Brewer thinks that computers are going to replace doctors. No, they're not. Doctors will always have a critical place and still do, always will. The doctor needs to communicate with the patient. The doctor is the one prescribing. So what K-Health had and what I originally set up for K-Health was a doctor piece. So now you go through the K-Health process. They're up to 37 states now, I think, with access. And at the end of going through that diagnostic exercise with the app, it'll say, would you like to speak to a doc? I've been one of the docs that's on the other end when patients said, yes, I'd like to speak to a doc, and there's some text and telephone type of interaction. What's exciting and what we've been meeting about today is setting up chronic care. What it's been in the past and so far is more of an urgent care type of interaction, like a digital urgent care access. We're having some exciting discussions about providing not only digital urgent care, but helping you and improve your access to high quality chronic disease care. So very obviously that's not ready for prime time, but it's something that is very, very exciting for improving cost efficient, much better quality and much better access to care in this space, in the things that we talk about. Okay, is coronary inflammation caused primarily by carbohydrates? Radnally. I would tell you, you're going to get a whole lot of people. There's a boatload of debate about that, whether it's carbs or plant-based versus animal-based. I used to be plant-based in my focus and approach, actually for almost 30 years. I will tell you, though, the research that's coming out now has become clearer and clearer. The original thoughts about plant-based were that LDL is what makes up most of the plaque. I'd love to be able to show you some of the research and some of the images that we have on the deck, but again, no images tonight. The bottom line is the research is becoming clearer and clearer. It's not the LDL, it's not the animal products so much, it's the carbs. They've shown that 4 or 5 hours at 180, especially at 200, and it's like a lawnmower came through and just cut out 2/3 of your glycocalyx on the intima of your arteries, injuring that intima and making it very possible for LDL, no matter what level you had, to go through that glycocalyx. So I think it's becoming clearer and clearer that carbs are a major, major issue. Now, if you're a 20-year-old or if you're a 40-year-old that doesn't have any insulin resistance and your body is keeping your blood sugar down 100 or 90 or 80, no matter what you eat, then no, carbs are not causing a problem. That's one of my pet peeves with this whole debate of plant-based versus animal-based or whatever else. There's this assumption that there is the same diet required by everybody. And I can tell you, I've got a mother-in-law who's 95. She's got a lot of insulin resistance, pure-blown diabetes. I have insulin resistance. I've met one of the criteria for diabetes. At one point, I did have a blood sugar go over 200. I don't take insulin, and most of us will not need to. I don't think I'll ever need to. My son, on the other hand, is 24 years old, and I don't think his blood sugar's ever gone over 110. So he can eat all the carbs he wants. I cannot, and Joy, my mother-in-law, certainly cannot, although she does. She doesn't listen to me about her carbs. Okay, so I'll leave that alone for a while. Trump Tribe 2020, hello from Las Vegas. Well, thank you very much for identifying where you're coming from, and hello to you. Cynthia Armstrong, hello from Chicago. Hello, Cynthia. Brad Jackson, what are the top things that cause inflammation, and what are the 2 or 3 best dietary foods or supplements one can take? Okay, so the top things that cause inflammation, as I said a few minutes ago, by far the most prevalent problem is insulin resistance or full-blown diabetes. Insulin resistance, metabolic syndrome, prediabetes, all you can get into some academic arguments regarding the potential differences between those 3 things. They're all basically, for practical purposes, our purposes, the same thing. And guess what? They're really the same thing as diabetes as well. The only difference is it's a matter of degree. So if I'm routinely at a position where if I eat a few carbs and my blood sugar goes up to 180, then number one, I need to avoid carbs. That's one of the most important things I can do. If my insulin resistance were to get worse and my blood sugar were to routinely go over 200, then I'd have full-blown diabetes. So that's the only difference between prediabetes and diabetes. As part of that conversation, you can see one of the major and most prevalent causes is prediabetes, or causes inflammation. Why is that most, what do I mean by prevalent? Common, I'm sorry, just the most common cause. Why is that common? Well, there are 3 major reasons why prediabetes is so common. One is the aging population. As we hit our 40s and 50s, especially at our 60s, by our 60s, over half of us are pre-diabetic. The University of California in LA, the School of Public Health, did a survey in California 2 years ago. And they saw over 1/2 of people, adults in California at that time, had prediabetes or diabetes. Now you would say, okay, that's 60-year-olds, so this is an issue of aging. They started at age 30. So there's some differences in terms of demographics, race, and clearly age, but prediabetes is very, very common now. Here's the other thing. The CDC is very conservative, but even the CDC will say there's at least 9 people out here in the world that have, Americans that have prediabetes that don't know it. For every one, 9 or 10 people have it and don't know it for every one that does know it. They'll also say there's, for those of you who are not medication haters, and I know there's a lot of medication haters, there's not a lot of non-haters, point about metformin. For about every person that's on metformin, there's probably at least 13 or 14 that need to be on it. Now, again, half of my patients don't want to take any kind of medication. I understand that. I actually delayed my own medication for about 3 years for similar reasons. Now, you said, what are some great supplements? Here's the thing. Here's a bottom line comment about supplements and lifestyle. Number one, by far, the most important thing in terms of managing prediabetes is lifestyle. You cannot change younger, although you can, I can see that I am having some connection problems. You can't change your age in terms of getting younger, but you can improve dramatically. One of the most common things I see is that people have a BMI, they're up around 30, meaning they're too heavy, and they have increased fat mass. That is incredibly important in terms of seeing patients, dealing with folks. That is the most common thing. Then you have some other things as well. Inflammatory diseases like rheumatoid arthritis, lupus, inflammatory dermatitis. Those things can cause inflammation as much as insulin resistance or prediabetes. And then we talked about, one thing we didn't talk about, I haven't mentioned it because so few of my patients and subscribers are smokers, is nuclear to your arteries in terms of inflammation. So it's not just smoking, it's tobacco products, and it's also vaping. So I'll get off of that topic for a while. Doc, you are right. I am leaning from this chat. I think you meant I'm learning. That was Charles Ransom. Thank you, Charles. 147 degrees west, My Health at PrevMed. It's My Health at PrevMedHeartRisk.com. OAG, Old Alabama Gardener. If you guys haven't seen OAG's channel, you should take a look. He is the original and best farm to table. He's far better organized than I am. He actually used to manage, do maintenance on rockets. So, and he's down in the Alabama area. So, an avid farmer, and actually takes you in his videos through how to plan a garden, how to clean out the garden, how to prepare the soil, how to get the right, all of these things. He takes you through about 3 to 4 months worth of development and growth. And then at the end, he's got this classic thing. He eats what he's making, whether it's vegetables or whatever. And he says, I wish I could share that with you. And I wish you could. Anyway, Old Alabama Gardener said, Dr. Brewer, how does homocysteine plasma test play in heart and artery health? That's a great question. Homocysteine, if you get levels up around 17 and 18, has been noted as a heart attack risk. That actually gets into things like leptins. A whole lot of people love to hate on Stephen Gundry, and I get irritated as well because, I mean, he's got some really good stuff. What's proven is here, but then there's a whole lot of other stuff sometimes you have to get through, and that can be frustrating. They tend to think the same thing of the issue of methylation, but I'm going to go there with methylation. This homocysteine issue that you brought up, OAG, does have to do with methylation. And I know I'll get a lot of haters about this issue, but if you look at the science, there is real and valid issues and scientific evidence supporting the issues around methylation. Unfortunately, just like the lectins issue, you get a lot of theory and unproven junk, but there's a lot of facts inside. Some of the facts around homocysteine and methylation are, methylation is a very, very big issue. And when you have a very high homocysteine level, what happens is the metabolic processes, are getting backed up, and you're getting a buildup of homocysteine because it's one of the metabolic feeders into a broken methylation system. So if the methylation system's broken, you get buildup of homocysteine. There's some practical things you can do. The most practical, simple thing is to take methylated B vitamins. One of the more common ones is Thorn, and I've taken Thorn Methyl Guard, and then you've got Thorn, THORNE, Thorn Methyl Guard Plus, and I've taken that for years because I've got a methylation problem. In terms of methylation, and again, you'll hear a lot of docs say, oh, they looked at it and it's not real. They haven't really looked at all of the science. As many of you know, I did some training in genetics and at Stanford, and I've worked with a genetics lab, My Genetics, for about 4 years now. So I've got easy access to methylation testing, and I have like a third to a half of our population. I have about a 50% decrease in my methylation function. When I see a patient with an elevated methylation, elevated homocysteine, I do tell them we could get methylation genetics, but on a practical basis, why don't you just take some methylated B vitamins? I actually am coming up and am getting a potential access to a source for that, and may start offering that through our channel as well. For those of you who have interest in this area, I would just tell you, I did a couple of videos a couple of years ago on the concept of what's called AREDS, AREDS. It is it's a place where they found that you actually get decrease in blindness associated with some very high levels, mostly of antioxidants. There's some methylation focus in there. And this is, again, research which is coming from great institutions like the ophthalmology program in Miami. I'll just leave that topic alone. Thank you for bringing it up, OAG. Cynthia Armstrong, would you please do another video on what to eat? Your information keeps improving and advancing, and I would really appreciate it. Well, thank you very much, Cynthia. I would love to. I won't promise that I won't get it out. I mean, that I'll get it out anytime over the next 2 weeks, because as you can see, like we got a lot of neat stuff that we're working on. And I have to tell you, I need to do some updates too. A lot of my most recent what I eat videos are probably a year or two old, and I've actually made some more changes. I did some more research on the issue of TMAO, and I won't go there tonight. But if you'd like, I'd like to do that. Bjorn to Fly, thank you for attending. You had a video about why most research is wrong with John. I'm going to butcher the name. Ioannidis. It's a Greek name, by the way. John Ioannidis. He's at Stanford. How do you cope with his findings that, especially research and diet, almost everything is wrong, and a dice would be just as good? That is a key issue, especially in prevention, because we know The top 3 priorities in terms of lifestyle are diet, diet, and diet, and then sleep and exercise and several other things go on. So I'm in sort of a no man's land in terms of science and what I do for a living. For those of you who don't know, I got my start in the ER and got focused on prevention because most things that take people into the ER, like heart attack, stroke, even a fish hook in the nose or thumb, are things that should have been prevented. So I went to the best place at the time, probably maybe still the best place available for prevention training, was Johns Hopkins. And loved it, ended up running the program there, and have been doing prevention ever since. Now, the reason I bring that up is my original training there and my function was in research. So I would clearly agree with Ioannidis's point that diet research is a tough place. There was a lot of research that came out just over the past 6 months regarding carbs. And there's still a lot of stuff that's just not known. I mean, you can see me, the nonverbals are true. It's like sometimes you just want to scream. But there's some things that things that you see, things that you work with on a day-to-day basis. I don't care if you're a plant-based guy. I don't care if you're a paleo fan. I don't care if you're a low-carb, keto, carnivore. I don't know anybody that's going to argue that having a BMI of 30 is healthy unless you are built like Arnold Schwarzenegger at the time that he won Mr. Olympia. I know I don't want to bring Arnold Schwarzenegger or politics or any of that in here, but here's the point. A lot of people, especially men, think, I hear this all the time. Oh, I'm big boned, I got a lot of muscles. Arnold Schwarzenegger's BMI at the time that he won Mr. Olympia was 30. So we're not talking, the research is clearer and clearer that it's not so much having weight, it's the fat mass. And if you look at a lot of the research around diabetes, cardiovascular inflammation, and fat, you see that we used to think fat was just storage. It's not. Fat is an endocrine organ, and it creates some adipokines and some other things that create inflammation. So the bigger your fat mass, the more inflammation you're driving. It also drives insulin resistance. So you could say, well, that's not nutrition. The bottom line is one of the major drivers in the nutrition space we already know, and that is BMI or fat mass. So you can push that aside and say, it doesn't matter which dietary place you come from. We know that one of the key points is how much you are storing in your fat. Then you can start taking some other logic issues as well. Yes, I'm very much aware that there's science and good science that came out recently about a J curve regarding carbs. I think the jury's still out on a lot of that stuff. But I think there's also some real clarity as well. I think there's plenty of information that would indicate that you don't have to get into the what Ioannidis is talking about in terms of dietary research. We wouldn't even call it dietary research that shows if you're diabetic, if you cannot metabolize carbs and you eat carbs and your blood sugar goes up and it stays over 200, 8, 10, 24 hours a day, then you're burning your arteries. You're going to blind, your arteries in your eyes are going to get inflamed and burned out. You're going to get blind, you're going to get a stroke, you're going to get a heart attack. etc. I mean, all of these come from the same place. So, yes, dietary science it can be a quagmire. But here's the other thing about that. Even within the dietary science, it's like over half of all science is wrong. I won't argue that. And yet again, one of my major things on YouTube is to try to show what is the scientific evidence, and here's one of the questions: what is good science and what is not? So again, I've gone on quite a bit about that. I think it's a great question. I hope this was helpful. Jeffrey Scott Fishman, thank you for joining. On keto, feel great, all aches and pains in joints gone. Lost 50 pounds, 5'6", weight 143 pounds. Congratulations, Jeffrey Scott Fishman. You keep that weight off, and you clearly, from a heart attack risk perspective and dementia and all these things I just went through, blindness, all these other things, you may have saved yourself a decade. I personally think more than that, maybe 2, maybe 3. 31-inch waist, excellent. Blood sugar at 85 and blood pressure at 102 over 65. Triglycerides are 72, HDL is 60. Excellent. LDL is 160. Now, a lot of people would say, oh, that LDL is terrible. You need to go on statins. You need to panic. You need to be concerned. I'm actually, this brings up a good point, and I'll just make this point. It's like 3 people just over the past week get started with me and or call me to get started because they went on keto, they lost weight, and their LDL went up, and their doc got panicked. And there is a thing out there called low-fat hyperresponders, LDL responders. Bottom line, what they're talking about, and I think it's Dave Feldman. He's got a whole bunch of channel on that. He's one of these engineers like Ivor Cummins. Got some very good logics, got some very good experience, some very good data. If you look this up, you have a question about it. Diet Doctor's got a good section on it as well. Bottom line is, a lot of people, maybe 20% of folks, will be able, even though they lose a good bit of weight on keto diet, will get a significant increase in LDL. They will panic, or their doctors will panic, and then sometimes they will panic. And here's what I would say. You know what? If I would much rather have that 50 pounds gone and deal with the LDL of 160. And it's really debatable right now. Excuse me. It's really debatable right now how much risk, if any, that LDL of 160 is creating. There's no question in my mind that it's a lot less risk than the 50 pounds we're creating before you lost them. So I've got a lot of patients that are the LDL hyperresponders, or lean mass hyperresponders is, I think, the term that David Feldman uses. Getting more and more of those coming in. To me, it's a great world to be in. It's a great thing. Over half of my patients now, by the way, are people that are coming in saying, I've lost over 30 pounds. And my response is what it was to you, Jeffrey. It's like, well, you've done the major heavy lifting, the hard part. What can I do for you? Why are you here to see me? And almost all of them say the same thing. That's right. I know I have done the hard part. I know that I've made the major change that I needed to make, but I still want to dial it in. And there's no question. In other words, it's continue to improve my lifestyle and improve my risk situation. And there's no question in my mind. My response is you can always improve your risk situation. So it's a very nice place to be. Jeffrey Scott Fishman, should I worry over high LDL? I think we just went over that. Taylor White, thoughts on sedimentation rate? Is it a marker at all for CV inflammation? That's a really good question. I don't know the science, the evidence around that. One of the things you have to wonder is how much of that is the case. But let me just, at the risk of making a fool of myself, and as you guys know, I mean, the start of the event was yet another more evidence that I'm not afraid to make a fool of myself. So from what little I know about the SED rates, it has a little bit more to do with the some of the proteins in the body, and quite so much to do with inflammation. That actually brings up the actual question: what is inflammation? You know, you hear about inflammation. You hear about inflammation in relation to cardiovascular risk. Unless you know specifically what it is, it can be kind of confusing. Here's what it is. It is taking friendly fire from your own immune system. So what happens is your immune system recognizes that this LDL is not supposed to be in your intima media space. And what it does is it is the same thing that it does any kind of thing that it recognizes that shouldn't be there, whether it's a tumor cell, or an infection, or foreign body. It starts sending in antibodies. It starts sending in things like immune cells, T cells, monocytes start coming in. They release enzymes to digest that LDL, and they also release things called what we call chemotactants, cytotactants. Big technical medical words, but in other words, they're sending out an alarm to other immune cells that there's a problem here, there's a foreign body, we want to clear it out. And all of that's working fine up until this point. It actually does its job. It actually dissolves that hard, waxy plaque in the artery wall. Unfortunately, those cytokines, those immune alarms, those chemicals, those enzymes, if they break back through the intima layer into the liquid flow of the bloodstream, they can cause a clot. If the clot's big enough, it goes to the heart, and it goes to the heart, that's a heart attack. If the clot is big enough and it goes to the brain, that's a stroke. If it, you have situations where it's microscopic, only wiping out a few hundred or a few thousand cells at the time. But that's one of the major mechanisms for dementia, blindness, kidney disease, heart failure. Because if you look microscopically at the tissue, you get 3 decades of continuing to have these microscopic clots, even though they're only wiping out a few hundred cells. Pretty soon, 24 hours a day for a decade, that starts chewing up the tissue, whether it's brain tissue, heart tissue, you name it. Jack Frost, can you repair the gym called? Not sure at all what that means. Randon Alley, thank you. At 60 and a CAC, coronary calcium score of 673, I'm trying to stay low carb. I'm low carb, Rand. I'm not like rabid keto, and I'm certainly not carnivore. I may try that at some point, but I think that's wise for most of us, unless you know exactly what your status is, how well you metabolize carbs. Once you get 60, especially 65 and 70, you should assume you're insulin resistant until proven otherwise. By the way, we'll be offering an insulin survey. And these are through Quest. So again, that's something if you're interested in finding out. To me, I would go with the insulin survey first and just see what sort of problem I had. Actually, I would probably order both. But again, that's some conversation you can have with Michelle. You can look through some of our videos and get a little bit more understanding of where you are, what your risks might be, and what your interests are, what your David Jones, I think you might be missing the damage from hyperinsulinemia. David, thank you very much. I was, and I tend to leave that out. So here's the thing. So David, thank you so much for bringing that up. I will tell you, it was about, we've been trying to get Quest and CHL to add insulin values to the OGTT values for a year. They finally agreed about 3 or 4 months ago. So now, in addition to getting just an OGTT, an oral glucose tolerance test, where you take a fasting glucose, take the 75 grams of sugar, fructose, and then 1 hour later you measure the glucose again. 1 hour later you measure the glucose at 0, 1, and 2 hours. Probably 2, maybe 3 times a month. Here's what I'm seeing, David. I remember a patient last week or the week before, their initial number was in the 80s. Their fasting glucose was in the 80s. Their 1 hour went up to like 115. Their 2 hour glucose was back around 8, 9. Most people would say those are really good numbers. But once we were able to get insulin there, the initial insulin was what, 10, 15, which is too high for basal insulin. In order to keep it down to a little bit below 120, his body was using over 100 of insulin, had to use over 100 of insulin to keep that 1 hour OGTT down below 120. And then it still was up in the high 30s at 2 hours. So again, to your point, David Jones, that individual, even though their glucose numbers are great, they've got significant inflammagen, pardon the technical term. They've got significant drivers for inflammation, and it's not coming from glucose, it's coming from insulin. Insulin does, there's plenty of clear evidence. Heart attack risk in people like I just described is one of the key areas where you see that evidence that insulin drives inflammation as well. Thank you very much, David, for that reminder. Jim Maley, hello from Thunder Bay, Canada. Hello, thank you very much for letting us know where you are. You know what? This question thing just flipped on me. I'm going to miss a few. Rob TO7, hello, Doc. Peter Attia has said he doesn't care if you're plant-based, paleo, keto, whatever, as long as your blood sugar stayed at a good level with low variation. I would agree with Peter. He and I share a little bit of stuff. I started off as an ER doc. He started off, I think, as a surgeon, and we both worked at Hopkins. B.E. Russell, I think I have more hair than Peter, and I think I'm a lot older. But for the most part, I agree with that. I agree with you. I appreciate you bringing it up. Anybody with any sense is going to say you need to manage. You need to eat to the glucometer. In other words, know what causes your blood sugar to go up. And if rice makes it go up, be careful about eating rice. I will share with you, probably most of you haven't seen those videos. If I go on the Prolon diet, those of you who know the Prolon diet, it's Valter Longo's diet. It's there's a little bit more of a plant-based approach to it because he wants to decrease fat calories and protein calories, at least for that 5 days. And he does have good research showing that it helps with insulin resistance. But here's the thing to remember, and here's one thing that I showed. I had my Libre, it's a continuous glucose monitor on, and about 20 minutes after I eat the soup, there's 2 soups in there. You go down to about 700 calories per day for about 5 days. You do have 2 meals. Each of them is like a powdered soup. On those powdered soups, they will take my blood sugar up to about 180. Now yes, 180. So the next thing that you might ask would be, well, Brewer, how long does it stay there? It's critical how long it stays there. And I'll tell you, I don't know, because I'm watching it on my CGM, my glucometer, continuous glucometer. And I know that if I start to get a spike like that, I can go out and take a walk, 20, 30 minutes, and it'll usually take the top right off of that. But again, that makes the point. Eat to the glucometer. And the point that you brought up, the quote from Peter Attia, it doesn't matter what your diet is. It matters what the impact is on your blood sugar. And I would add, as David pointed out, it also matters the impact on your insulin. I'm going to butcher this name. I'm sorry. Liao Fendi. Hi, Doc. A question. Do you know if rosuvastatin, I think you mean rosuvastatin. I hope that's what you mean. Omega-3 clopidogrel antiplatelets would cause side effects of bruising. Clopidogrel, clearly. Clopidogrel is an antiplatelet drug, as you mentioned. And yes, any of the antiplatelet drugs can cause side effects of bruising. Loretta Dillingham, retracted. Richard Morris, hi, Dr. Brewer. How does one improve one's HDL level through diet? FYI, I'm from the UK. Thank you guys for letting us know where you're from. One of the first things I'll do when I see a patient, even if I don't have the insulin resistance, almost everybody's going to come to me with a cholesterol panel. And I can get a really good handle of their risk very quickly. And I'm not looking at LDL. I'm looking at triglycerides and HDLs. And here's what classically happens. If you get a triglyceride over HDL that's elevated, it indicates you probably have insulin resistance and or diabetes. In other words, too many carbs. Now, how does that happen? Well, insulin has a couple of effects. Not only does it wants to get, insulin is made, and the two effects that it has both result in dropping the blood sugar. The first effect is to move blue sugar out of the blood and into the cells where it's safe. The second, and a lot of people don't know about this, is insulin shuts down fat burning. Well, fat burning is usually triglycerides. That's what your love handles, your subcutaneous fat is. So if you are constantly in a place where your muscle and liver tissue push back and resist insulin, you're constantly in a place where your blood sugar's hanging around 160, 180, too high. Insulin values, by the way, then are hanging around 30 when they should be less than 5 on a basal level. 9 on a fasting level, up around 30, then your insulin is obviously not being successful at getting the sugar from the blood into the cell. In addition, though, it's shutting down fat burn. So that's why your triglycerides are going up. Why did I go down that bunny trail? Because of your question of how to decrease or increase HDL. Cut the carbs. Increasing the triglycerides, having a high continued insulin level, high triglyceride level tends to chew up HDL. I won't go into the technical reasons why that's the case, but cutting carbs is a great way to increase HDL. Another way to increase HDL is to, there is a supplement, niacin. I know there's a bunch of niacin haters. And probably in any audience. There were a couple of studies, Aim High, and I can't remember the name of the other one, that talked about, niacin doesn't work. That's not true. I've got 3 or 4 videos on niacin. And niacin does tend to help. We're getting long in the tooth. Had a lot of great participation. I would ask you again if you would help us by helping us with our pilot on offering the inflammation panel. I forgot to put in a plug for some of the other activities we've got going on. We've got a book coming out in not sure when, hopefully this fall. It's all about how to detect plaque. We've got an event, a full event where you can come in, get your CIMT, get all your labs, and talk about those with a 2-day boot camp type of environment. Intense focus on your lab results and how to interpret them, what to do, and what some of the risks are, the science that we've been talking about tonight for about an hour. That's in Louisville. You can find that on our website. If you don't want to do the labs, you can come in and not do the labs, just get the CIMT. Many people have been asking how to get a CIMT. We set up a CIMT access tour, intimate media thickness test. It's it's an ultrasound that we take of the carotid artery, and it shows how much plaque you have in there. 99 out of 100 of these ultrasounds are not an IMT. Most of them just look to see if you have enough plaque to impact your artery, your flow. This is a different type of thing. It uses software to detect more than if you have an impact on your flow, how much plaque you actually have. Because the vast majority of strokes and heart attacks occur in people that don't have enough plaque to impact the flow. And a stress test is a flow study, but just a lesser amount of plaque. So that's why you look at to see just how much plaque do we have. You can do that with calcium score. The advantage to calcium score is that it looks at the heart. The disadvantage to calcium score is that it only looks at calcium. It doesn't look at that soft plaque that creates the immediate danger that we talked about early on. We do have a couple of courses. We just finished the third course. We're getting that up and rolling. We've got a course on cardiovascular inflammation, what it is, how to understand it. And again, it goes into a little bit about how to get some of the testing yourself. That's on the membership page. If you haven't heard about the membership page, that's on the website. And the website is PrevMedHeartRisk.com. PREV is in prevention, PrevMedHeartRisk.com. Thank you very much for your interest, and I'm going to sign out. Well, I think I am.